Good afternoon and welcome everyone to the second of our four-part webinar series on the prepared practice, expert advice on readying your office to reopen. My name is Pete Cerrone from Darby Dental Supply, and I'm also joined by my colleague Jeff Daly and Jim Gerson from CareStack. Today's session, Infection Control Guidelines for Reopening, will be hosted by Dr. Shannon Mills on behalf of OSAP. Dr. Mills is an internationally recognized expert in dental infection control and safety. Before we get started, I'd like to note that as an attendee, you are automatically set to mute. We encourage you to submit questions using the Q&A feature, and we'll aim to answer as many as possible at the end of the session. And if you enjoyed today's session, please join us for part 3 tomorrow, Managing Cash Flow and Supply Chains as your practice reopens, taking place at 1 p.m. Eastern Standard Time. We'll have the registration link in the Q&A session at the end of this seminar. So without further ado, I'd like to turn it over to Jim Gerson from CareStack.
Great, Pete. Thank you very much. And if you want to go ahead and advance your slide, that'd be great, Dr. Mills. So CareStack is thrilled to be a co-sponsor of today's webinar with Dr. Mills on readying your practice for reopening. And this is going to be the only plug for CareStack, I promise you, in this program today. Many people may not be familiar with us. We're a 100% cloud-based practice management solution for the complete management of your dental operation. And we typically work with 2 types of clients. The first is the practice that's growing, but has real concerns about how to provide a contactless experience for the patients when they reopen, in terms of bypassing a common waiting room and having a clipboard and things like that. And they see technology as enabling their practice, just don't know how to get there and need a little bit of help. The second type of client, while they're also visionaries and ambitious, they've grown frustrated and aggravated by managing multiple different subscriptions to run the dental practice. And as you can see on your slide here, they're frustrated by managing one subscription for charting, one for reminders, another one for a check-in kiosk. How about patients doing portal access for forms and so forth? And so these subscriptions have really kind of created a mountain of overhead, and it's produced a lot of sleepless nights for these practice owners. And they just want to get out of this situation and they don't know how. And so hopefully you fall into one of those 2 buckets if you're attending today's webinar. And if so, we encourage you to visit carestack.com and request a free demonstration. And now I'm going to turn it over to my colleague, Jeff Daly from Darby Dental. Thank you.
Thanks, Jim. Appreciate it. So as Jim referenced, this will, I promise, be our last shameless plug of the day, and then we're going to turn it over to Dr. Mills. So thanks to CareStack and Dr. Mills representing OSAP as he provides some important updates today on how to transition some of the guidance that have come out from the various bodies into, I think, tactical and tangible steps that dental practices can take to help protect themselves and their patients. So about Darby, what you probably and hopefully already know about Darby is that we partner with our customers to help keep their dental supply costs down. And over the past 10 years or so, we've built a suite of solutions to help resolve the challenges that our customers tell us they face on a daily basis. So some of those services include IT services, mechanical equipment service, and so on. And then our final point for today, and maybe most salient given the times, is just a reminder that for Darby's entire 70-plus year history, all of our account managers have worked completely remotely with our customers. So in today's world, that means no extra bodies walking into your practice. And we're happy to be able to say that our team is still here and able to and ready to support our customers. Our team of well-trained experts is 100% functional from the safety of their homes and standing by to help practices in any way that we can as they, get ready to ramp up and return to work. If you're interested to learn more about the ways we can help your practice, please feel free to reach out to one of our account managers. And with that, I'll turn it over to Dr. Mills to help guide some of our customers through this difficult time.
Right, thank you very much. And welcome all of you out there. I gather that we're probably spread all over the country. So when I say good afternoon, for some of you, it's probably still good morning. But thank you for taking the time to be with us today. 2 disclosures. I am an OSAP member dentist, and I'm presently an independent consultant, having now been retired from the military, from academia at the University of Nevada, and as a, and nobody turn it off when I say this, but as an insurance company executive for one of the large dental insurance companies on the East Coast. But I'm now retired and independently operating as a consultant. I am getting no compensation for this presentation and a commercial product during it. And I do have a couple of photographs in here. They're strictly for instructional purposes and I'm not endorsing them. I just thought you wanted to know that. Before we get started with the program directly, I always like to begin with a little historical perspective. And I guess if you live long enough, nothing's new under the sun and things tend to repeat themselves. So I'm old enough, maybe a few of you are as well, to have been around the last time of infectious disease drove a major inflection point in the practice of dentistry. And that would have been in the early 1990s when a couple of things happened. Number one, because of the high rate of carriage of hepatitis B among healthcare workers, the OSHA, the Occupational Safety and Health Administration, released a set of regulations known as the Bloodborne Pathogen Standard. And initially that didn't have that much effect on dentistry, and dentistry wasn't really even the focus of it, although there had been recorded a number of transmissions of hepatitis B from dentists to patients in practice. The main drive was really focused on hospitals. But then HIV, which had only been, the virus had only been identified really a few years before, rose to the front when on the front page of People magazine, we had a photograph of a very photogenic young lady named Kimberly Bergalis, who had been infected with HIV in her dental office. And even to this day, no one's entirely certain how it happened because it didn't happen again. But if you were around at that time, you know that things changed dramatically. Wet-fingered dentistry was not just a phrase, it was a reality for many of us. We used gloves for surgery, but not necessarily for restorative. And I had endodontists tell me that they had to quit because they couldn't possibly turn a file with a gloved finger. So we all know that's not true. And I'm very proud of our profession because they rose to the occasion. And the consequence of it is we reformed dental practice. Some of it was very painful. Some of it was expensive. But we made the changes we needed to do to protect our patients, our staff, and ourselves from exposure to bloodborne pathogens. And for most of us, standard and universal precautions, and OSHA still calls it universal, are really muscle memory. We just do it almost without thinking. And it's really done a great job because we've effectively really protected folks and not had any significant, we've had one hepatitis B transmission reported over the last 30 some odd years. In one case that we know of. So we've done a great job, but now we're at another inflection point because now we have another disease for which the stuff that we've committed to muscle memory, the bloodborne pathogen stuff, is not sufficient. We're going to have to make changes again. So what I'd like to go through with you today is take a look at the current guidance that's out there. And we have fortunately or unfortunately, we have several different sources of guidance. Fortunately, they're not 100%, but they're mostly on the same page. And that's a good thing because if we had major disconnects, it'd be a bigger problem for us. But I'm going to share with you where to find this guidance. And I will give you some of my oversight of it. In an hour, and it's less than that, we can't possibly cover everything in detail. So what I'm going to try to give you is a broad overview. Toward the end, I'm going to bring in a subject that hasn't been discussed very much, that's not directly, but is indirectly associated with the pandemic. And we'll get through that as we get to the very end. So if you have questions, be sure and put them up. You can't interrupt my train of thought with a question because some people told me I don't have one. So, but as we go forward, if you have it, if I think it's really important, I'll answer it then. Otherwise, we'll hold it for the end. But be sure to put them up and I'll look at them and we'll see if it's something that needs to be addressed right away. All right, let's talk about the resources that you have available to us. I am very, very proud to be a life member of the American Dental Association. And this organization continues to surprise me with the level that it's able to operate in dealing with the real issues we face as professionals. And the ADA Center for Professional Success has put together the COVID-19 Center that has a huge number of resources, including a lot of really great information. I'm going to talk a little bit about some of that related to infection control and, of course, occupational safety, which is its companion piece. Now, I am here representing OSAP, and OSAP is the Organization for Safety, Asepsis, and Prevention, for those of you who don't know. And we are the only organization in dentistry directed exclusively at infection control and safety in dental practice. And if you're not familiar with us, I urge you, you know, when you get a chance, as soon as you're done with this program, to take a look at the resources they have. They have a comprehensive list of, for example, links to every one of the pieces of guidance and many, many more that I'm going to show you today. And you can see, I do have a question for my sponsors. Will this presentation be available later for the participants? All right, well, we'll find out. I hope that it is. If so, these links should be live.
Yes, it will.
Now, then we have we have two government agencies that are driving the vast majority of guidance. The first is our Centers for Disease Control and Prevention. They have an oral health division. And on their website, they have a number of guidelines that are interim guidelines that are being developed. Now, those are going to transform over time into definitive guidelines. But right now, the facts are there are too many things we don't know to actually find out what the real, you know, what the final guidance is going to be. We've got, as we once heard years ago, we've got known unknowns, and we've even got unknown unknowns. And we've got to deal with all of them. Now, the Occupational Safety and Health Administration has likewise come out with something they typically don't do. They've actually written guidelines, they've written guidance. And that's because of the urgency of the situation. Normally, what OSHA does is promulgate regulations to which you are obliged to comply, and with penalties if you don't. Not so in this case. Their guidelines that they've written are voluntary. They want you to look at them, and there's only minor differences between what they and the CDC are saying, and I don't think there are material differences, but there are some things that are a little bit different. Everybody's moving at such a breakneck pace. Coordination is not 100%, but it will get there. I'm certain of that. Now, let's talk a little bit about the CDC interim prevention guidance, infection control guidance. Now, they have four key concepts that they built this around. First of all, that dental settings have unique characteristics in healthcare that warrant additional infection control procedures. Other than respiratory therapists and maybe ENT physicians, practically no one is more intimately engaged in the oropharynx, which is the source of most of the transmissions, or almost all the direct source of almost all the transmissions of COVID disease and SARS-CoV-2 virus. It comes from the mouth and the nasal passage. Okay. They also believe, and this is something that not everybody agrees with, but they still believe that we should be postponing elective procedures, surgeries, and non-urgent dental visits. We're going to talk today about how you can do those things, but you need to know that the CDC and OSHA both don't entirely agree with that idea. We need to proactively communicate to both staff and patients the needs for them to stay at home if sick. Now, I've managed dental clinics in the Air Force. I ran a residency program. One of the hardest things to do was to get people who were really motivated, either by the need for a paycheck or just motivated because they felt it was their duty to be at work. It's almost impossible to get sick people to stay home. It's a huge challenge. We've got to stick with that. We've got to make it work. And you got to know the steps to take if a patient with COVID-19 symptoms or a healthcare worker with COVID-19 symptoms ends up in your facility. Both can happen. So, what are some of these go forward? Now, how is this disease spread? According to the CDC, it's thought to be spread. Notice thought to be spread. We don't know all the answers. Primarily through respiratory droplets. We're pretty sure of that. And it happens when a person coughs, sneezes, or coughs. You ever had a patient cough in your face or sneeze in your face while you're working on it? It happens. We don't know about airborne transmission. And it says right now that it's unlikely, but it's really a better thing to say is it's unknown. We don't know. We hope it's unlikely. We hope it doesn't happen. But we can't say that with absolute certainty at this point. Again, it's a new disease. We're still learning how it spreads. We still don't know everything. And we're still learning things every single day about the severity of illness. We're now learning that it caused more than pulmonary disease. We're starting to see these new syndromes arising in children who had asymptomatic cases of COVID-19. We do know the virus survives in aerosols for hours and on surfaces for days. And it's possible. We also believe that patients who are pre-symptomatic, that is that they've acquired the virus but have yet to demonstrate symptoms, or people who go on to remain asymptomatic throughout the course of their disease. And by the way, we don't even know yet, but many of them are not going to be entirely free from post-illness complications. Okay, now on if you read this before 27 April, it's been revised. So here are the revisions that were posted just about a week ago. To address asymptomatic and pre-symptomatic transmission, source control should be universal. So again, it's interesting. What we had was the guidelines for special protective measures in medicine, droplet precautions, aerosol precautions, airborne precautions, were always added on to standard precautions based on what we knew about the patient. But now we really have an addition. It's more than anything else. It's almost an addition to standard precautions, because source control should be in place for everyone entering the dental setting, because we don't know that someone's pre-symptomatic or asymptomatic. So we also need to actively screen everyone who comes into the practice. This includes patients, but also healthcare workers. So when you come to work, you shouldn't come to work if you have a fever or any symptoms. If you're the boss of the practice, if you're the manager or the dentist. But when your other workers come to work, you need to be checking them for symptoms and fever before every shift, every time they come to work. And that's, I think, seems extreme, but I think it's a valid recommendation. Okay, we also know that rotary handpieces and ultrasonic instruments, and lots of things we do in dentistry, generate droplets. They contain water, saliva, blood, microorganisms, and debris. In some cases, with some of the instruments, these can be in the form of either respirable droplet, nuclei, 5 microns or less, or even smaller droplets, which form aerosols, which can contain viable virus. But does it contain virus in numbers sufficient to cause transmission, or that can actually be ingested into the oropharynx and into the lungs to cause the infection? We still don't know. So we do know that surgical masks protect mucous membranes from droplet spatter. We know they don't protect inhalation of airborne, but for most routine contact with patients, that the surgical masks are probably sufficient. I think that'll be reinforced elsewhere in the presentation. Now, there are no data that have demonstrated that the dental offices have been infected. Anybody in the dental office has been infected by contact with a patient or another healthcare worker. But let's be honest, I think that's only going to be a matter of time. It is going to happen. So we're going to have to all do our best to make sure it doesn't become the kind of thing that frightens the public or gets people to be reluctant to come to the dental office. So it's really important that everybody step up to the plate on this for those reasons. By the way, OSHA, and this is also in the CDC guidance, but we'll see it again later, has dictated that dental healthcare professionals are in, and this is an overstatement because they're in the high or very high risk, depending on the kinds of procedures they do. And that'll be further clarified later in the program. And again, person-to-person transmission is one of the main ways it's spread, and that's if you get within 6 feet of a person who is loosed a blast of droplets into the air that we ingest because we aren't protected. But it also becomes contaminated surface, and of course the old touching our eyes and face and nose and mouth, okay? The virus can remain viable on hours to days, depending on the type of surface, humidity, and heat, other conditions. And that's why we have to probably, even though we've done a good job, I've said that before, we've done a great job on bloodborne pathogens. This is a very, very much more infected. You really could not get infected with HIV or HPV from a doorknob or a countertop or a toilet seat. That's not true with SARS-CoV-2. That can be transmitted by contact with surfaces in the workplace, and we're going to have to up our game. We don't have any choice. Now, let's go to what OSHA says. So OSHA describes dental office personnel and the jobs that they do, and it's meeting all four of the risk categories. The lowest risk is people who perform only administrative duties in non-public areas. Say, for example, if you happen to be a larger clinic and you have a lab technician, as long as you're practicing clean lab practice and you're disinfecting things, that person's not involved with other staff members. But most offices may not have anybody at that level. If you have someone who does nothing but stay in a back room and submit reimbursement claims or do other kinds of accounting or administrative duties, they may be at the lower risk. But they still, if they come in your practice, everybody will wear a mask. Now, medium risk means they're providing for folks providing urgent or emergent dental care that does not generate aerosols to patients who do not exhibit any of the signs or symptoms of COVID-19. And those folks are at medium risk. Anybody, by the way, that works in a busy staff work area, so if your front desk person has to come to the back, now hopefully nobody's still doing the paper records, but some are. If someone has to come back constantly to see you or moving in around the office, they're going to be considered medium risk as well. High risk is anytime you enter a space where a patient has, a patient is there that has COVID-19 or the signs and symptoms thereof, even if they don't have a positive test. Anytime you provide dental care not involving aerosol generating procedures to a known or suspected COVID-19 patient. And by the way, we should not be doing any routine or non-urgent or emergent care on patients that we know to be test positive or to exhibit signs and symptoms of COVID-19. And you also at high risk if you're performing any aerosol generating procedure, even on well patients, because as we've said before, we don't know if they're carrying and spreading the virus because they could be pre-symptomatic, asymptomatic. Now, you are very high risk if you're performing aerosol generating procedures on a known or suspected COVID-19 patient or handling specimens, which we don't typically do. Although we could, for example, if we're doing oral surgery and we have to take out a tooth, we're handling a specimen, so to speak, from an infected individual. And this is an area where, sometimes the only solution from an oral surgery perspective is to take out a tooth. But we'll talk about some strategies to try to avoid doing these high-risk procedures. We should do everything we possibly can to avoid pushing ourselves into that very high-risk category. And I think for the most part, we may be able to do that. All right. We can't rule out, as I said, we can't rule out absolutely, even though it's said to be unlikely. And the CDC says both things. They say unlikely, and then they say can't be eliminated. So we just don't know. But if we have to do a patient who has actively got COVID-19, we really shouldn't be doing those patients in our practices unless we have a negative pressure room, a place that's designed for treating patients for airborne precautions. So by and large, these patients need to be referred. Now, by the way, for many people, that's not possible. There's not a healthcare facility necessarily in their area that has the ability to do that. So this presents a conundrum, but it's still the recommendation to do that. And if you have to see them for examination or evaluation, obviously you're going to wear the highest level of protection of PPE. Now, what the CDC recommends is to postpone elective procedure surgery. Now, again, I've said this before, this was earlier on, but this is what they believe. And they think for a number of reasons. Now, it's becoming less and less, but not entirely the case, that we're also doing that to preserve PPE and other supplies for our frontline healthcare workers who are treating COVID-infected patients. So that's a transformational stage that we're in right now. So that's one of the reasons that it's going to be alleviated over time. But the other ones, we just have to use the utmost caution as we move forward because so many things we still don't know. Now, again, if you're going to keep people from coming to work sick, you've got to have a sick leave policy that works. I don't know what you're doing in your practices. I really don't even know what the norm is. But you need to have flexible, non-punitive, and it needs to be consistent with your regional and also with national. Most everything is state or regional right now. Public health guidance. We don't have really a national policy on that. If patients call in to say that they're sick, you need to let them stay home. And you know, you got to say, well, somebody might be malingering. I think I wouldn't make that my first concern right now. And again, if an employee becomes sick at work, and you need to send them home. And that can happen because the people can be well 1 minute and start showing signs and symptoms really in a very short order of time. Now, as far as patients, CDC, ADA, OSHA doesn't describe this, but ADA and CDC both make the same recommendation, and ADA goes farther by giving you some excellent tools to work with, which I'll show you. Telephone screen all patients for signs or symptoms of illness. Everyone, every single one. It doesn't matter what their age is. You have to talk to the mom sometimes, but you need to talk to everybody because the child, though they may be asymptomatic, that child still has the capacity to infect you. Now, if possible, you want to delay, so you have a person with a dental emergency, they've got endodontic pain, they've got a little swelling, a pericornitis, for example, just 2 examples, or they've lost the restoration. Remember, if they are currently showing signs and symptoms, well, one of a couple things is going to happen. They're going to get better or they're not, but either way, the disease is going to resolve. It's going to resolve in no more than about 14 days, probably a lot less. So you can delay or defer that treatment. You typically, unless the patient has a life-threatening or emergency, you may be able to put it off. And you can also do things that you might normally not do. We know that the surgical solutions to odontogenic pain are usually the best, and that writing antibiotic prescriptions or writing opioids or pain medications isn't the first line choice for long term. But in these cases, it may be necessary to do stuff you wouldn't always do. So telephone triage and determine what's needed. If you can keep them from coming in by giving them a prescription, I think that's a prudent thing to do. So, and again, teledentistry, it's okay to have the patient take their iPhone out or their Android, take a picture of what's going on in their mouth, and you take a look at it. There's lots of things we can do on the way of teledentistry. Now, it's up to it depends on what your state permits in terms of law, and it depends on what your dental benefit companies that you work with. The teledentistry can be a reimbursable expense. Now, if the treatment can't be delayed, no, it can be delayed. Be sure you give the patient also the home care instructions they need to do. Now, I'm moving fast, and I know that, and I do talk fast, but I got a lot to cover, and I hope it's not too much, but I'm trying to keep it moving forward. Again, I'm not going to go into read this in detail. I want you to go to the ADA website. I want you to look at the patient screening form they have, and I'm not going to read this to you, but they have an excellent document there that you can use. You can print it out and customize it for your own office. So that's what you want to do. So you need to pre-screen, and you need to understand the priorities for testing. Now, they're going to vary with where you are in the country and what's available, but you know, again, healthcare facility workers, if you are a healthcare facility worker, you have high priority for testing. So if you think and if you're treating patients, now if you're just staying home and watching Hallmark Channel or whatever, that's not the case. But if you're actively treating patients, you are a high priority for getting tested if you suspect you have any symptoms or if you've been exposed. You can just tell them that you're a healthcare worker. They'll take care of you. I recently called my doctor to have my asthma medications adjusted. They asked me if I had a cough. I said yes, and then they asked me. Then they had to go through the algorithm, and they got down is that do you live with? I told them I wasn't active right now, and I told them though that my wife worked at the hospital. Immediately it triggered the algorithm, and I had to go give a test, and thankfully I'm negative. So thank God if I was not, I can't transmit it over the internet. That's all good. So again, the symptoms, you kind of know those now. I think everybody does. But that's who needs to be tested. But just know that you should meet the criteria for priority testing. Now, staff protective status. This is right out of the ADA guidance. I think it's brilliant. A soft launch is a good idea. If you're going to open next week, you need to get into the office this week with your team and start going through all the strategies and things you're going to do. Establish policies and procedures for things that you're going to do routinely. But because with something like this, things can happen and can go wrong, knowing that no plan survives first contact with the enemy. Also have an idea what you're going to do when things go wrong. And some of the things that people are going to do. So people aren't setting their hair on fire and running around in circles. So practice all the routines. Patient flow. Who's going to get the patient? Bring them to the office. Are you going to have the patients wait in their car? And then you're going to call them to come in. When they come in, are you going to give them a mask as soon as they enter the building if they don't have one? Or if you don't trust their little cloth mask, are you going to give them one of yours anyway? These are all things that have to be decided. You can't just show up the first day of work and expect it was just like before you left. So you've got to get out there and do that. You got to give people places to change their PPE. And by the way, come up later, people should not be wearing scrubs or clinical attire to work and then wearing it home. If I go to the supermarket and I see somebody walking around in scrubs, I'm giving them way more than 6 feet of space. Okay, and it's just I think it's not a smart thing to do. But you've got a small office where you're going to change clothes. You got to figure all that stuff out. Okay, you got to figure out what different people in the office based on their duties are going to wear. Who needs N95? Who just needs a surgical mask? Okay, and then reinforce. Hand washing, alcohol hand wipes, and disinfectant of contaminating surfaces, and safe removal of PPE. You got to cover all that stuff. Now, gowns need to be considered. You can have reusable gowns or disposable gowns. They need to be changed so they become soiled if you're working on non-aerosol generating or spatter generating procedures. They have to be disposable or single use and then thrown away. Now, I know we have shortages. There's some waivers on that right now, but right now that's what we should be doing. Cloth gowns have to be laundered after each use. We have a place for that. If you don't have your own laundry equipment in the office, you're going to have to make an arrangement with a commercial laundry. Okay, and again, this is the thing I just mentioned to you with the scrubs, wearing street clothes, changing into your clinical attire and then covering that with a gown. Short sleeve scrubs are not PPE. Scrubs that you wear out of the building are not PPE. We should be using only long sleeve garments. Whether you wear head covers or foot covers, who knows? But I will tell you this, when those aerosols and droplets fall out of the air, go to the floor.
You're fired up at Darby.
Huh? Okay, someone's live there. They fall to the floor. So that's one reason you may want to think about that. Now, PPE, what's the right level of PPE? OSHA has described, it lets you know, and they tell you what they think you should do. It's guidance. This is not a regulation. Dental procedures involving aerosol, non-aerosol generating procedures. You can wear a clinic smock or a long sleeve scrubs or whatever. You don't necessarily have to have coverings over it if you're not generating spatter or aerosol. Still got to wear gloves, eye protection, and at least a surgical mask. That's for well patients. However, if you're generating any kind of aerosol, I think we've made this case pretty clear, you're going to need to use a NIOSH type, whether it's an N95, a KN95, or some other equivalent. And you need to wear more than just your loupes and Z87.1 safety glasses to get the adequate protection. So you're going to need a face shield of some kind to see anybody where you produce aerosols. And again, the ante-ups when you go to anybody who may be COVID-19 positive. And to be honest with you, if you're doing aerosol generating procedures on a person with who's infected with COVID coronavirus, you shouldn't be doing that in your office. That's just pretty straightforward. If you want to get the real skinny on respiratory protection and PPE, ADA website has some excellent videos that you can go and watch that were done in conjunction with OSAP with two of the top experts in the field, Eve Cuny and Kathy Eklund, who are going to take you through how to do that. And I'm not going to cover that anymore right now. So scheduling, let's talk a little bit about scheduling. Now, when you're calling the patients on the phone, what do you do with them? Don't schedule any non-emergent patients exhibiting risk factors that are identified by pre-screening. So the patient doesn't have any symptoms yet, but they told you that they just flew here from New York City on a packed airliner. Of course, there's no such thing right now, but just say they did. That'd be a reason to ask that person to defer. You don't even have to say anything. yeah, my next available appointment is in 2 weeks. You don't even have to tell them that you're quarantining them. You just make sure they don't come in right now. So if they show anything that raises the hackles in the back of your neck, defer their treatment. Okay, make a note that as to what the reason was and whether they're coming back. So when they call back in 2 weeks, or you make the appointment, you double check this. Okay, and again, local guidance and testing priority. If you need to send somebody for testing, do it, but you have to know what the local requirements are and capabilities are. Because every patient poses some risk, I'm going to suggest that you prioritize urgent and emergent patients over patients at lower risk, at least early on until some of these things sort out. Because the patient who has high dental risk and can have something go wrong and end up having to go to the negative pressure room, okay, poses exactly the same risk to you as that person that just needs a prophy because they like the way it feels when they rub their tongue over their teeth after the prophy. That person has the same risk of making you sick as the other person does. So you're experiencing the same risk for a low return on benefit. So I give that priority. This is my opinion, by the way. This isn't from CDC and this isn't from any of the other agencies. They're just my thoughts, my views on the subject. So I would take my lowest risk patients and for the time being, not schedule them for their routine second visit a year or their second prophy if they don't need it. And I would instead get in the patients, I think, or have the potential to go south. The only thing worse than having COVID-19 is having COVID-19 and a raging toothache or a space infection at the same time. Okay? Again, for all patients, choose the least aerosol or spatter generating treatment, droplet generating treatment. And again, teledentistry is a legitimate way to approach this. Again, your ability to bill for it and so forth, where you can call it teledentistry, really depends on how it's regulated in your state. But where it is legal, it may even be covered. So you need to check with benefit providers on that. And you can legitimately bill a patient for it unless it's prohibited by your participating agreement with an insurance company. Okay, and again, you have to use airborne isolation capability for those really super high-risk patients. Now, if you have someone on your staff who tests positive, again, the ADA offers excellent guidance on this, and I'm not going to belabor this excessively, but they base it on the CDC guideline for risk assessment, healthcare personnel, and return to work. You need to know about return to work guidance, and that may be governed by your state. You should probably follow whatever the return to work guidance is at your largest local hospital, because their employee health department will have a policy that's based on evidence. I recommend you try to figure out what they're doing. You usually can call and ask them. By the way, that's what my wife does for a living. That's how I kind of have a handle on that. But if someone does have a test positive, it can be highly disruptive, and depending on local quarantine policies, could end up with you having to close your clinic or shut down for a period of time because other people in the clinic may become exposed as well, and they may all have to go into self-monitoring or quarantine. So I got a suggestion that occurred to me. Actually, it wasn't entirely my idea. A colleague of mine suggested it, so I'll pass it on. If you're in a multi-dentist office and you have more than one dentist, you may want to stagger the days the dentists work. Create a team, a dentist, assistant hygienist, even a front desk person who works like Monday, Wednesday, Friday, and then another dentist will make work another day, or he may even have that morning and afternoon shifts. So if one team ends up going down because of an exposure, you can keep working and you keep seeing your patients and maintain access to care. And if that works for anybody, just let me know, because I'd like to know that it did. Okay? Let's talk a little bit more about our friends, the aerosols. Coronavirus has been isolated in human saliva. The study that's just been published in Clinical Infectious Disease, and there's a link to the study there. It's Kai Wang To from Hong Kong. They were able to identify viable virus in human saliva. They also, in many cases, were able to detect the virus in human saliva, but there were no viable viral particles present. So what this means is we still don't know the degree to which this poses a hazard. But I'm going to say for myself, I'm going to assume that it is until it's proven otherwise, okay? And again, we know about the pre-symptomatic, asymptomatic, no reason to belabor that. And we also know about the rotary instruments. Again, limiting aerosol and droplet generation. Engineering controls are always the highest level of control. And to do that, the number one thing I recommend we do is discontinue use of ultrasonic scalers or endodontic instruments entirely. Put them in the closet or in the trunk of your car because they really have no place until we better understand what's going on with all this stuff. And again, our old friend, most people don't use for restorative or other procedures, or other isolation devices can reduce the risk of aerosols when we have to have them present due to the need to do some kind of an instrument, something with a high-speed handpiece. Hand scaling is going to be the standard. Rubber cup prophies, I recommend getting rid of those for the interim because they generate spatter. If the patient loves them and you have to explain it, just say this is for your safety and mine. And by the way, there's no evidence in the literature that polish at the end of the procedure has any clinical benefit. People just love it. I love it, let's face it. So again, try to avoid the use of the high speed with the coolant water spray. The water is gonna, or even with airspray, because it's gonna pick up saliva and put it into the aerosols. You can, however, go back to the 1950s, and in some cases, using a slow speed handpiece without a coolant water spray may give you some options in restorative treatment where you need to do that to finish some, or to start or finish some restoration. I know that's kind of a jarring thing, but in some cases, it may also preclude the need to even use anesthesia, which could be a benefit as well. And again, air water spray, don't ever use the air and water spray together in the mouth unless you've got it isolated with a rubber dam. I wouldn't even use it with an isolate device because you still have the potential to mobilize saliva with that. But a rubber dam is a good one. By the way, rubber dam does generate more aerosols. Some people are going to point that out. However, if the water you're using for dental treatment is treated and meets drinking water standards, that's an aerosol, but it doesn't contain coronavirus. It's going to contain some small number of heterotrophic bacteria, typically. So a friend of mine described to me a procedure called a closed mouth irrigation, where you put the water syringe in, you squeeze the water into the mouth with the patient's mouth closed, have them swish, and then evacuate it with a, either you could use an HBE, but typically evacuate it with a saliva ejector so that there's no spatter. So I thought that was a smart idea. He calls it the jacuzzi technique. Anyway, again, always consider the most non-aerosol generating options. All things that may already be in your armamentarium, but we've mostly been using them in pediatric dentistry, to be quite frank, or as interim treatment as temporaries. But these are all things that are viable alternatives to aerosol generating treatments and are remunerable. Most of the dental insurance companies out there are going to reimburse you for it. Silver diamine fluoride is a huge new tool in our toolkit. It does arrest caries. It does darken the teeth. It's absolutely the case. We're now mostly using it on kids, but it absolutely has the same benefit on adults. The only reason that's just an artifact of the benefit plans that are being provided by your dental benefit companies. They should be able to cover this for adults, and hopefully none of them will be enlightened enough to do so. Atraumatic restorative treatment is a technique of removing gross caries, as much caries as is reasonably possible, with hand instruments. And again, if you want to use a slow speed to help this out, that's just fine. And then placing a glass ionomer or Compomer restoration. You can also put silver diamine fluoride down initially to enhance caries control, and then place this in place. By the way, a glass ionomer or Compomer restoration can be submitted for benefit as a tooth-colored restoration as long as it's placed and you have reason to believe that it's not going to need to be replaced, within weeks or months. Most benefit companies have a time limitation on colored restorations of about 2 years. And so again, it depends on the location and size. In some cases, it is an ITR. It's going to have to be replaced. But if you think it's going to last, bill it as a tooth-colored restoration. Sealants and preventive restorations, these things are preventive sealants. These things are also things that are just as beneficial on adults as they are on children for incipient or very early lesions. And I'm suggesting glass ionomers are better. By the way, there's a trick in the way the literature is described. Plastic sealants last longer, are retained longer, but glass ionomers are equivalent in their ability to prevent caries. So even though you don't see the glass ionomer, it's still working, even though its body of it may be lost. And you don't even need to use a spray to remove etching agents, no more droplets. Again, for these procedures, a level 2 or preferably a level 3 surgical mask and a regular protective eyewear, not face masks necessarily, are adequate to provide protection. Again, if you want to do these under dental dam, you even adding more safety. When you have to use a high speed, again, maximize the use of high volume evacuation. Use rubber dam or an isolation device like an Isolite. Again, not necessarily, there are other products, but that's the one I know you all probably recognize. Again, for any restorative or endodontic procedures, an endo needs a rubber dam, by the way. And you must wear an N95 or equivalent, face shield, goggles. And there's a challenge. I don't know how I do dentistry without my loupes, but face shields kind of are tough on that. So it's another challenge. Everything's not easy. The other thing is that once you've generated an aerosol, it's present in your operatory. We don't know if it's infectious or not. We don't know what risk it poses. But you want to see if you can do something with your heating and air conditioning contractor to figure out if you can increase the air exchanges per hour, or you may want to add either an HVAC installed treatment like an electrostatic device to remove dust and microorganisms, or HEPA and UVC products that are now in the marketplace. I'm no expert on them, but I'm in the process of getting smarter, and you probably are too. I hear they're going out, they're flying off the shelves, and if you wanted one today, there may be a chance you won't even be able to get one, but it's something to consider. Not a recommendation at this time. Now, if you've got multiple operatories, one thought, if you've got enough operatories to do this, and especially if you're staggering your schedules, just don't use that operatory again for about a half an hour. I think that's typically enough for most of the particles to drop out of the air. So just move to the next operatory and don't go back to that one. Put a timer on it and don't go back to it until you've determined it's safe. And again, more barrier protection, but more plastic and more disinfectant. And is what we're going to do, and disinfect stuff we don't routinely do now. We never disinfected the chairs in our waiting room. We never disinfected doorknobs or toilet handles. Yeah, that's probably what we're going to need to do, at least on some kind of a periodic breakdown. Now, this is the last bit. This is the part that's kind of a surprise, because this isn't directly about COVID-19, but it's about our response to the pandemic. Most of us have been out of our office for quite a long time. And what's happening now, and this is an article out of Nature on 28 April, is the lockdown shifts. We're recognizing that there are hazards in stagnant water living and the microorganisms that are living in both our premise plumbing and our dental equipment. So during periods of disuse, biofilm is going to increase in these lines, leading to our faucets, our toilets, any showers if we have a bathroom with a shower, and they may contain Legionella or things like aquatic mycobacteria, which can be pathogenic. They're opportunistic pathogens, Legionella being the worst of them. And it's actually the most dangerous respiratory pathogen. Until this came along, it was the most dangerous respiratory pathogen in America until coronavirus, maybe, I think, is knocking it off its perch. Now, CDC has issued guidance on measures to assure safety, and they're available at cdc.gov. So they're not oblivious to this either. Now, you want to make sure when you do this, your water heater is properly maintained, because water heaters and hot water tend sometimes to increase the amount of Legionella present. You have to flush your system. I mean, not just your water lines. We'll get to that in a second. You need to flush all of the water line, all the faucets, shower heads, even the toilets and urinals in your office. And flush both hot and cold water to all points of use. And again, you may have to do it in stages because it's going to drop the pressure somewhat. And the idea is to replace all the existing water and reintroduce a chlorine residual into the building water piping. And they recommend that you flush it until the water temperature, maximum hot water temperature, is reached. And that should be sufficient. If it were me, I'd let it go a little longer because we can be infected from this water as well. Then dental unit water lines. We know biofilms grow in dental unit water lines. First line of defense, contact the manufacturer of your dental unit. The dental unit manufacturer gives you the shrug. Then you got to go to the waterline treatment device or product that you're using. Now, I don't know, I'm probably talking to a few of you who aren't doing anything right now. You know, if this was ever the perfect time to do this, this is it, is to go ahead and look into what you need to do to start managing water in your practice. This also is not a trivial issue. And if you want to take a look, OSAP has a white paper on dental unit water lines available on their website and recommendation. I strongly encourage you to read that. So we're going to close quickly here. Units equipped with separate water reservoirs, if you have those, this is what you should have done before, and if you haven't, hopefully you did. I recommend with water reservoir-based units, take the little straw device, if you have one of those, take that off and just flush the unit dry. That'll help reduce biofilm buildup. And you need to take those iodine or silver cartridges off. When you do that, just put the regular straw back on. If you have the products that have the cartridge systems or the conditioning systems, that's like Denapure or Stericyl, you need to probably have been and now go in and run the units periodically to make sure there's a residual germicide in there to control biofilm formation over the time. Now, what the ADA says is to shock your units prior to resuming treatment. Totally agree. Follow the manufacturer's instructions, either of the dental unit or of the waterline product that you're using. Okay, that should be done. And then the thing that's not mentioned, and I think you need to do, is you need to test. You need to determine if you've got meeting the CDC's guideline of 500 or fewer colony forming units and using a heterotrophic plate count method. You can do that either by sending your samples to a dental waterline testing lab. You can go online and find there's a number of them out there. They all give good results. Or you can use on one of the in-office test kits, which are also available from a number of different sources. These are these little paddle devices that are very easy to use. And only use the water when you determine that it's safe. Now, where this may come back to haunt us a little bit, remember COVID is affecting the respiratory systems of our patients. And those that survive are seeing problems with persistent pulmonary problems. The last thing we want to be doing is showering them and showering their respiratory system with opportunistic waterborne pathogens like Pseudomonas or mycobacteria in the post-pandemic world. So it's even now, I think, even more important than ever to manage dental water lines properly. Okay, this now is our time for questions. I want to thank Darby it's an OSAP super sponsor, among other things, but also for today's program and CareStack for their support for this webinar. And also direct you to www.osap.org for any other, just to see a huge number of resources. By the way, membership in OSAP is very reasonable for a dental practice, and you get a whole lot of tremendous benefits from doing it in terms of information. They don't just pull, they don't just wait for you to call them. There's actually a lot of really cool stuff that comes on the push that you will find extremely useful. So that said, I'm ready for any questions anybody may have. I've given you just a few minutes left, but I didn't see any pop up yet. But we can do that now.
Hey, Dr. Mills, it looks like we have a few questions that are coming in from our audience down in that bottom box in the Q&A feature. Sure.
All right, I see them there. Okay. All right. I'll start with the earliest one from Dr. Mihaichuk. I hope I got that right. Yeah, the problem with N95s is they're still not available enough, and that's going to change over time. If you have to, the level 3 mask is your next best bet. So go with the highest level of ASTM mask that you can get. By the way, that's what OSHA says. If you aren't able to get it, that's what you can do. You know, there are rules around N95 masks and I didn't talk about fit testing. That's in that ADA OSAP video that I told you about that's available. But right now there's some waivers on the requirements for fit testing. But once we get settled down, you need to get yourself into a situation where you can fit test. You're going to use N95s. You need to talk to your local occupational or health practice, and they can help you do that. You can also get your own people trained. There's online courses. But fit testing is important. But in the meantime, we just have to do what we can do. We have to, again, I don't even like Donald Rumsfeld, but twice I'm going to quote him. I guess we have to fight with the army we have. And that wasn't a good answer then. It's just the best answer we have right now. So is there data that shows aerosols from slow speed? Well, if you use water spray with slow speed, yes, you're going to get aerosols. You're going to get some particulates, but they're typically not going to be dropped. If you're doing it dry, you're not going to get a lot of droplets. So I think the slow speed is still a fairly safe option. But again, if you're using water spray with it, then it's going to generate droplets. I hope that's the right answer. And Anonymous, I hope we got it for you. Joanne asked, is to reduce length of time aerosolized droplets remain in the air, are true HEPA filters, negative? Yeah, these are, I don't know if they're necessary yet, but I think they may be a good idea. And I mentioned that they're going to be hard to find right now. You know, one thing we have is that some of the HVAC, there are devices that can be put in to your HVAC system that electrostatically remove dust and microorganisms in the air. There are products that use HEPA or even higher levels of filtration. There are products that are using UV light, either UVAV or UVC. There's even discussion about using UVC lights in the opera room and maybe put them in one of the bulbs in your ceiling lights because, and again, I'm not convinced this is true, but they say that UVC light doesn't cause damage, skin or corneal damage or eye damage, and it's safe. I want to see that confirmed to make me happy. So OSHA guidelines call for fit testing. I think I answered that. Fit testing, there you can train. If you have an infection control coordinator in your practice, and you should, if you have one of your staff members should be designated, they can go online and learn how to do fit testing. Or your local, any local occupational health medical practice that specializes in this should be able to do it for you or train a person to do it for your staff. The clarification on the gowns. The OSHA says the gowns must be or should be disposed of between any patient when they are contaminated. So that would be an aerosol generating procedure. If you're just doing sealants, you don't have to change it. If you're doing anything in the soil and there's no soiling and there's no contamination visible, you should be safe. But you should err on the side of caution. Err on the side of caution. Lean forward and change more often than you need to, rather than less often than you need to and ending up with an exposure. Okay? I would never use a Cavatron in the current circumstances. I know they have the extra oral vacuum. That's a choice you have to make. I would never use one in the current situation. So the polish, that's your judgment call. It's not generating any aerosols, but it is generating spatter. And I know when I've polished teeth, I've gotten it on my garments. If I'm doing this and I don't want to have to change that garment at some cost between patients, then I don't want to use it. So I would avoid it, and it'd save you a little money too. So now the other thing about that, about the gowns, again, OSHA and other health authorities, they're granting waivers on saying, on reuse, okay? And I'm not going to get into reuse in this talk. There's information out there about it. I wasn't comfortable enough with it right now to share that, but they talk about hospitals are now reusing N95s, but they're using a tool you don't have. They're using vapor phase hydrogen peroxide. There's none of that in the dental market, although I did see it in Chicago midwinter, tabletop vapor phase hydrogen peroxide sterilizer that you could use in a dental office, but it's not FDA approved. It's made in Korea. We may see those. I don't know. But finding a source of N95s, I wish, if I knew how to help you find one, I'd be out there making some money doing it, probably. No, I wouldn't. But if I could get you in touch with somebody, I would. I would not put hydrogen peroxide in the chair water bottle right now until somebody's tested whether that's a good idea. There have been people do it before. It's off-label use if you wanted to do it. The other thing I didn't discuss was mouth rinses. I believe we're going to see recommendations soon on the use of pre-procedural mouth rinse. If you want to do one, I don't think it does any harm. The question is whether it does any good. There is evidence that chlorhexidine is not, I repeat, chlorhexidine is not effective against coronavirus. So what you're seeing out there already on the internet, and I've actually seen a study that I don't know if it's going to get published yet, that talks about the use of peroxide and the use of povidone, polyvinylpyrrolidine, or betadine-based mouth rinses, because they are effective in vitro against coronaviruses. The other reason I wouldn't put hydrogen peroxide in there is if you're going to vaporize it, if people are going to breathe it, we don't know what's going to happen. So I'd be careful about that. Yes, patients with asthma. You should be careful about patients with asthma anyway, because we know that the endotoxin that's present in untreated dental unit water systems can exacerbate asthma and can worsen asthma in susceptible patients. So, and asthmatic patients have a higher risk. Although actually there was a letter in the Lancet that said surprisingly, people with asthma and even some people with COPD appear to have some resistance against the worst effects of coronavirus, which is utterly and completely different from what we expect. Okay, can we use diluted bleach? Diluted bleach is in the literature, okay? So you could use the literature to base it on, but if you don't know what the components of your dental equipment are, and you don't contact the dental manufacturer and you use diluted bleach, you could damage your unit. We know many units will tolerate diluted bleach, and at least one manufacturer still recommends it. And I'll just say, if you do it, dilute it 1 to 10 to 1 to 13, depending on the higher or lower concentration in the original bleach, no more than 10-minute contact time. And do it until you get the results you're looking for. Again, I'm not advocating it. You should use follow the manufacturer's recommendation. So we all have the staff take the COVID-19 test. If you have enough tests in your community and you can access that without depriving somebody else of it, then I see there's no problem. We want to test everybody. And so if you can get that done, I have no problem. But keep in mind, you can be tested today and be exposed tomorrow. So you can't test every day. You're going to still have to rely on symptomatic measurements. Any services? I don't know that, but if you talk to your dental representative from the, I don't know whether Darby would do that, but then whoever does your dental dental repair technician that works on your units, ask them if they do that. And by the way, if you don't have a dental water line, an older unit, you don't have a water bottle, or you don't have an inline system, again, this is the time when things are slow to get an installation done. There are counterfeit masks out there, and they're not all KN95s. There are counterfeit masks out there that claim to be, U.S. made N95. They say 3N on. It's interesting. I read one the other. One of them says instead of NIOSH, it says something like Nisho on it. Which reminds me when I lived in Korea years ago. They'd have counterfeit jeans, and instead of Levi's, they'd be Levi's. They look like a Levi, but they look at the label, they're not. So they're trying to pull the same thing. And it's probably the same people that were doing that back then. Plastic enclosure, or bay type, yes. This is something that's good. Or just get one of those, go to the local medical supply shop and get one of those enclosures that, I don't know what they're called, those curtain things that you get that they use in hospitals. And just get one of those. Anything you can find will work. They're fine. By the way, some people are also putting plastic, just like the grocery stores, they're putting a plexiglass protection at the front desk. And that's something you can do. KN95s are fine. OSHA says KN95s are fine, and so does CNC. Hey, if we're going to follow anybody or use anything, I want to use Korean stuff right now because they're kicking it, and we're not. Okay, yes, the K95s are also supposed to be fit tested. Again, there's a waiver on it right now. You're not going to get fined by OSHA for not doing fit testing. There will be a time come when you will, again, but not now. Hand scaling and skip polishing. Again, if it's not visibly soiled, you didn't generate an aerosol. No, you don't have to. But if you have any reason to believe that you've contaminated or touched your garment during the procedure, and it's almost as hard as touching our face, maybe harder, then by no means you don't have to change it. That's in the guidance. That's just not my opinion. That's it. Where are we? We're moving up fast. Surgical caps, not necessary, but I think that you have to judge. I think I'd wear one, but they're not required. Level 3, that an unverified K95. Well, if you think it's counterfeit K95, that ought to use a level 3. At least it meets the ASTM standards. Pedo office, all we do is prophy and minimal restorative. Again, you don't need to polish, just scale. If you have a lot of stain, then use one. That's not an absolute prohibition. When I threw that out there, that's just a should. When you don't have to use one, don't use one, because you're going to generate spatter. You may contaminate a garment that you could otherwise reuse. I'm not worried about, Shannon Mills didn't say rubber cups transmit coronavirus. It never said that, and that's not true. I'm just trying to do things that you don't have to do if you want to reduce spatter. That's all I threw that at drop it. That's why I threw it in before. RDHs and DDS have different perspectives. Well, that's one of those perennial problems. And, when I speak on infection control, most of the time, almost everybody in my audience is an RDH or an assistant. And so I know very well that our opinions are different. But, you just have to work it all out. And what all you have to do, you cannot make anyone put you in a position where you are at risk. So no employer can tell you you have to do something to be at risk. And you have choices, and sometimes they're painful, but you have to, if you make those choices, you have to make them. But try to use persuasion and try to use the evidence to make your case. No, there's no spray mix that you can use. Right now, that's still up in the air. We're monitoring that. There's nothing I can see that we can use in dental offices. You cannot autoclave them. And you cannot use germicides on them. You cannot spray them with germicides. So there is guidance. By the way, I'm not going to go into this because I didn't read this in detail, and I haven't used nitrous probably in 25 years. But there is guidance in the ADA documents on nitrous. So you can take a look at that. You should use disposable masks. I think that's the best thing there. That's really the big deal there. But they should recirculate, so I don't know. Well, you can't do a traditional prep with a slow speed. Although, by the way, dentists used to. G.V. Black did. He used it with a pedal drill, and he cut those preps we all had to cut in dental school, those sharp line angles. However, I'm not saying that. I'm talking about things like caries excavation or removing unsupported enamel and doing more of an ART type restoration. So an ART restoration can be a permanent restoration if you place it and depending on the size of the prep. It's not going to work on a cusp. You're not going to replace a cusp. You're not going to probably do a lot of class 2s, but if they're class 1s, you can do a permanent restoration with a slow speed, spoon excavators, and glass ionomer complement restoration. So, I've done some stuff. I've done this. That's practically. I used to work at a hospital that didn't want me to use anesthesia on pregnant patients, and so that's all I did for several years was those kind of preparations on the people in my pregnant women group. With all aerosols produced during the day, with or without use of HEPA, how can we take our masks off? Even with no treatment, wear your mask until you're out of the operatory. Don't take it off until you're outside the operatory. That's the smartest advice I can give. If you have a door, close it behind. And give it time for it to settle, especially if you've got air treatment systems. I live in a part of the world, by the way, where some older buildings that have dental offices don't even have HVAC. They just have baseboard heaters. So whatever's in there is just in there. There's not much you can do. They probably are particularly in need of getting some air purifying system. Yes, you may be able to be tested for COVID-19 even if you show no symptoms, if you inform the public health authorities of the local hospital that you're starting to treat patients. So if you're treating patients, you may be able to make the case for getting it. I can't guarantee this because availability of tests is still a challenge. And whether you meet the threshold or you answer the right answers on their algorithm to get tested, I can't tell you in every location, but I think it's worth a try. When I say after every use, I didn't mean you take it off and launder it right away. You put it in a basket or a bucket, which you handle aseptically with gloves, and then you launder everything at the end of the day. That's the recommendation there, or send it off to the laundry. This is a big pain. This is something we haven't had to do so much. So, no, you don't have to change the gum after every patient unless it's visibly soiled. If you did an aerosolized procedure with aerosol or droplets, again, high-speed handpiece or anything like that, you have to assume, even if you can't see anything on it, it's contaminated, okay? But if you didn't do an aerosolized procedure, minimally invasive procedure, not necessarily, unless you know you touched your garment or you see visible soiling on it. Yeah, you need to use the hood test. There are different kinds of tests out there that can be used, but that's what you're supposed to use. Unless OSHA issues a waiver or someone in authority tells you it's okay to do it that way. Again, my wife talked to somebody at the hospital she works at, and in their airborne contamination rooms, they wait 30 minutes. However, remember, they've got 6 or more air exchanges per hour in negative pressure. But that's probably a minimum, and I don't have a definitive answer. So please don't say that I did, and I'm not basing that on evidence. That's something we need to go to the literature to learn. Talk to your local hospital, ask what they do, and follow that. That's what I need to do. Okay, a hypochlorous spray. These products, if they're EPA registered, you can use any EPA registered disinfectant. For one that has a coronavirus viral claim. By the way, it won't say SARS-CoV-2, but many of them have a claim for SARS, the original SARS-CoV or MERS. or other cold viruses. Remember, cold viruses are also in the coronavirus family. So you got to use an EPA registered disinfectant. Fogging.
Hey, Dr. Mills, looks like we're 10 minutes past the hour. Can we, how about we take one more question and then
all right, let's take one
bring
more.
it to a close.
Yes, I have heard about fogging with hypochlorous acid, but I claim no expertise, and I haven't necessarily seen enough in the literature to understand it. It logically should work, and I know there's a lot of interest there, and I've talked to people in that area, but I'm not going to recommend it. I'm going to say we need to learn more, and when you learn, tell me, okay? All right. I'm sorry we ran over a little bit, but there were so many great questions.
That was great. So thank you, Dr. Mills, OSAP, Darby, and CareStack for the valuable information today. Thanks to everyone who submitted really relevant questions. A recording of this session will be made available on darby.com in the coming days, and we invite you to join us tomorrow at 1 p.m. for part 3, managing cash flow and supply chain as your practice reopens. And you can register for that and all future sessions on darby.com. So thank you again, everyone.
Thank you so much, Dr. Mills, for your time and great information. Thanks for joining us, everybody.
All right, that was my pleasure. Wish I could have seen everybody. That's the only thing I miss. So, but you guys were cool.
Likewise.
Right, take care.
Thanks again, Dr. Mills. Really appreciate it. All right. Bye-bye.